Marwa.
Hi, thank you, Simal. Hi, everybody, and it's my pleasure to co-chair with Dr. Simal Desai. My name is Marwa Abdallah. I'm professor of dermatology at Ain Shams University, and it's my pleasure to introduce Haitham Saleh. He is one of our team at Ain Shams University who is going to present a comparative pilot study of dipstick versus open spray cryotherapy technique as a depigmentation treatment for vitiligo. Over to you, Haitham.
Good afternoon, dear professors, doctors, and colleagues. You are listening to Dr. Haitham Saleh from the Department of Dermatology and Venereology, Ain Shams University. First of all, I would like to thank Professor Dr. Marwa Abdallah for her keen guidance and support throughout that work. Well, today I'm going to introduce a comparative pilot study of dipstick versus open spray cryotherapy techniques as depigmentation treatments for vitiligo. Depigmentation is a practical solution for extensive vitiligo patients who have failed to respond to medical therapy and have obvious cosmetic disfigurement due to intervening patchy pigmented areas. But what about the depigmentation methods? Depigmentation methods include creams like monobenzyl ether of hydroquinone, which is the only FDA-approved for depigmentation in vitiligo. However, its long duration of treatment and the undesired pigmentation in non-treated areas may limit its use. Lasers like Q-switched lasers may be tried, but they are painful and expensive. On the other hand, cryotherapy is cost-effective, rapid, permanent, and has excellent cosmetic results. But there is no consensus on the ideal method for the use of cryotherapy in depigmentation. While cryotherapy acts through intracellular ice formation, which leads to irreversible tissue damage, it is selective as melanocytes are more sensitive to cryo damage in comparison with other epidermal cells. It requires no anesthesia, dressing, sedatives, or antibiotics, and it has short preparation time. But how is it prepared? Actually, there is wide variation in the reported protocols for the preparation of cryotherapy in depigmentation. Dr. Van Giel used the dipstick method. Dr. Gupta preferred the single open spray, while Dr. Dinozzo and his colleagues used the double open spray method with success. So there is controversy, there is a gap of knowledge, so our aim of the work was to compare the efficacy between dipstick and open spray cryotherapy techniques as depigmentation treatment in vitiligo, and also to evaluate the cosmetic outcome and possible side effects of each technique. Accordingly, we carried on a prospective comparative left-right clinical study on 10 generalized vitiligo patients. Vitiligo universalis and vitiligo vulgaris patients with areas recalcitrant to repigmentation on exposed skin, especially the hands and face, both females and males who are 12 years and above, were included in our study. Patients with active infectious or inflammatory dermatoses, with hypertrophic scars or keloids, with cardiac, hepatic, or renal disorders were excluded. For each patient, the dipstick method was performed on the left half of the body, while the single open spray and the double open spray methods were performed on the right half of the body. The dipstick method was performed by gently rolling 3 times over the intended areas of treatment by a cotton tip that was dipped into liquid nitrogen, while the single open spray and the double open spray were performed by a cryoprobe that was held approximately 40 mm away from the skin surface, and spraying was done using either a single freeze-thaw cycle in single open spray or 2 freeze-thaw cycles in the double open spray. Treatment in all batches was restricted to only 1 single session. Post-treatment care included strict photoprotection and topical antibiotics for signs of infection. Evaluation of treatment response was done after 8 weeks through assessing the depigmentation grade and the patient satisfaction with the cosmetic outcome using a scale from 1 to 10. Also, the side effects reported for each test area were recorded during a 1, 2, 4, and 8 week interval visits. In general, there was no significant difference in the capacity to induce depigmentation between the three methods. There was higher patient satisfaction with the Dipstick method, and side effects were significantly more in the double open spray method, and they were mainly pain during the depigmentation session and scarring reported at the follow-up session. Now I will demonstrate some cases in the format of before and after, but before I will start, we have to be cautious and remember that our goal herein is to depigment and not repigment. Our first case was a 23-year-old female patient, acrofacial vitiligo of 10 years duration, with residual pigmentation on the forearm and hands. Depigmentation using the Dipstick method showed some degree of depigmentation. Similarly, using the single open spray and the double open spray showed some degree of depigmentation. So in that case, there was an equal degree of depigmentation between the three methods. Another case was a 59-year-old female patient, generalized vitiligo of 7 years duration, with residual pigmentation on the neck and hands. Depigmentation using the Dipstick method showed no effect. Similarly, using the single open spray showed no effect, and the double open spray also showed no effect. Moreover, there was an area of scarring reported at the follow-up session. So in that case, there was no depigmentation in all methods, but scarring in double open spray method was of note. Another case was a 32-year-old female patient, acrofacial vitiligo of 17 years duration, with residual pigmentation on the face. Depigmentation using the Dipstick method showed no effect. On the other hand, depigmentation using single open spray and the double open spray showed some degree of depigmentation. So in that case, the open spray method took the upper hand. Our last case was a 38-year-old female patient, generalized vitiligo of 25 years duration, with residual pigmentations on the forearms. Depigmentation using the Dipstick method showed some degree of depigmentation. On the other hand, depigmentation using single open spray showed no effect. Similarly, using the double open spray showed no effect. So in that case, the Dipstick method took the upper hand. So as to conclude, in general, cryotherapy is effective in inducing depigmentation in generalized vitiligo patients, with no significant difference between the three methods. However, the double spray method appeared to have significant side effects. On the contrary, the Dipstick method was well tolerated. And at last, our take-home message is that cryotherapy is considered as a cost-effective, rapid, and easily available depigmentation tool. However, we recommend the use of Dipstick method of cryotherapy. More studies with greater sample sizes are required to confirm these findings. And finally, thank you.
Thank you very much. Thank you very much, Haitham. I had a question because as we saw the recording after you finished, we found out that you did not mention the duration of spraying. So can you tell our audience, please, how long did you spray the lesions? For how many seconds?
Hello everyone, it's my pleasure to be with you today, especially with you, my professor, Dr. Marwa. Well, it's a good question. The duration, our endpoint is the frost, and it shouldn't exceed 10 seconds for all methods.
Okay. I just found out that there was a question from the audience, from Dr. Huang, who had the question. So it was 10 seconds, right? And I repeated it in the double spray.
Yes, it's 10 seconds, and the frost is our endpoint. This is most important point.
Okay, and there's a question from Dr. Hamzavi. He asked for freezing, and is there a surface area limitation? Did you have a surface area limitation, or what did you do? Can you tell us, please?
Well, it's a very good question also. The limitation for the surface area, it was for restricted for contact cryoprobe therapy.
It was published by Dr. Mohammad Ramnish from Iran, year 2000. He used the contact cryoprobe. So the contact cryoprobe show limitation in the surface area, but the open spray and for the surface area. I hope it's clear.
There is another question from Dr. Wang. With monobesyl ether hydroquinone treatment, there is a concern of repigmentation after successful treatment. Is that the case with cryotherapy approach as well? What do you think? Did you have
Well, in our
viruses in
study, we didn't experience a repigmentation. In our experience repigmentation, but in the literature, there is repigmentation after cryotherapy reported, yes.
Okay. Now we have to move to the next speaker.